Good afternoon, everyone. We will be starting our webinar, New Treatment Options for Obesity, Managing Costs and Care, in about a minute. We've got a lot of interest in this topic. My name is Bunny Ellerin. I'm the CEO of an organization called ZHNY, and we lead a group called the New York City Obesity Working Group. Which is just about a year and a half old. We have brought together 4 leading minds to discuss this topic. And I am going to introduce each of them and ask them, as I do, an opening question, which is around the perception of obesity and how that's evolved over the past year. So I'm going to start with Dr. Catherine Saunders, who is board certified by the American Board of Obesity Medicine. She's an expert clinician. She's a clinical assistant professor at Weill Cornell. She's also co-founder of IntelliHealth, which she'll talk a little bit about. But IntelliHealth was in fact in today's Wall Street Journal. So congratulations, Catherine. So tell us as I said to everyone, keep it short, but how has the perception of obesity changed over the past year?
Yeah, so it's been absolutely fascinating over the past decade to witness the evolution of people's perception of obesity. Historically, there was this idea that obesity was a lifestyle problem or an issue of a lack of willpower, rather than a disease requiring medical intervention for most people to be able to treat effectively. So I spent the first part of my career spreading the word that obesity is actually a complex, chronic, and refractory or difficult to treat disease. Over the past couple of years, and really more pronounced this year, there's absolutely been a paradigm shift. Many more people now acknowledge that obesity is a disease and it's reasonable to treat obesity medically. However, media coverage of the newer, expensive anti-obesity medications has created this impression that obesity is a simple disease that should be treated with a one-size-fits-all short-term approach. So we now need to really kind of focus our communication on the fact that obesity is not a straightforward medical condition, but rather a heterogeneous, chronic, and refractory disease that requires personalized and long-term care.
All right. Next up, we have Dr. Mark Cunningham-Hill, who's the medical director for the Northeast Business Group on Health, represents many, many employers throughout the Northeast. Dr. Cunningham-Hill is an employee health expert who's been in the space for many years and is really known for his ability to create, identify, and implement high-quality workplace health initiatives. So, Dr. Cunningham-Hill, what's your take? How is, from your lens, from your vantage point, how has it evolved?
Yeah, 2 things, I think. I think one of the first things is that I think COVID sort of taught us that obesity is a significant, risk factor. And so just to add to all the other risks we know which are associated with obesity, it just highlighted, some of the challenges. So I think it sort of helped raise awareness that, there is a desperate need to address obesity and sort of change some of the trajectories we have within this country. The other thing is, again, a little bit, the celebrity take on some of the new obesity medicines, I think in some ways just undermines the whole initiative in terms of, you have an injection or a simple treatment and it's done, and you sort of sit there and sit there on the couch watching TV and miraculously the weight disappears. And we know that's not how it works. And it's a complicated disease that's multifactorial and needs a whole sort of village to sort of treat it. So I think that's a shame in some ways, because the new medications are amazing and they offer real promise, but it's getting them into the right patients. And I know we're going to dive into that later on today.
Right patients and also right paradigm. Next, we have Christine Gallagher, who's the Senior Center Administrator for the Redstone Global Center for Prevention and Wellness at the Milken Institute of Public Health at George Washington University. And in her role, Christine provides the overall direction, leadership, and program management for the Stop Obesity Alliance. Christine, it's great to have you. And you've been at this for many years, way before the before it became popular. So how has it changed for you over the past year?
Thanks, Bunny. So the Stop Obesity Alliance is an alliance of over 60 different organizations and corporate members. And we have been around prior to even me starting at GW. So it's about 15 years for Stop, and I've been at GW for about 12 years now. And I think the biggest change that I've seen this year is that we're finally moving the needle away from folks saying that diet and exercise is going to solve this problem. And we finally have other tools in the toolbox. And what we're hearing from are a lot of different large employers, small employers, states, state Medicaid plans, and so forth, that are beginning to look at this and what type of coverage should be available to their beneficiaries. So that's what we talk about a lot. We're also involved at the federal level with a big legislation to try and get Medicare to cover anti-obesity medications and expand the providers that are able to provide intensive behavioral therapy. So lots going on.
Yeah, and we'll hear from you about what a comprehensive benefit really looks like. And last but certainly not least is Max Cartman, who is a pharmacist by training and is the strategic consultant at Valued Pharmacy Services, where he works with many clients, employers, and other brokers on what he says is everything to do with the pharma benefit. So Max, you're entrenched in this world. How has it changed for you?
Yeah, Bunny, it's the perception has really changed dramatically, I think. When we look at obesity coverage, I think it used to really just be a very quick line item that we could almost kind of skim over, right? It was something where we could say, exclude these medications and move on to the next item. Whereas now, I mean, Dr. Mark, Dr. Saunders, we've kind of already alluded to, like, between the media trends and the pipeline, the new medications that are out there, we're having much more robust conversations and much more. I don't think a week goes by where I don't have an entrenched conversation with an HR team about covering obesity medications, and rightfully so. The members are asking about it.
Well, and given what today's Wall Street Journal article had to say about certain employers leaving and other articles we've seen, I can imagine that you've got a very packed schedule. So we wanted to ground today's conversation in science and the epidemiology, right? Because many people still don't recognize that obesity is a disease. It's a chronic disease. And so we have our expert, Dr. Saunders, here, who's going to give us a little background, not too technical, but really just to help you understand the nature of this as a disease, just like CHF and diabetes. So let me turn it over to you, Dr. Saunders.
Sure. Thanks, Bunny. I could talk about this for hours, but I'll try to keep it to 3 minutes.
You won't.
I won't. So what happens when individuals with obesity develop excess weight is that the area around the hypothalamus, which is the energy regulatory center in the brain, actually becomes inflamed. There's literally swelling around this area. And what that means is that feedback signals from our digestive system and from our fat cells don't get through as well to tell our brain how full we are and how much fat we're storing. So what this does is it leads to this sort of feed forward mechanism where people with obesity often feel more hungry, develop cravings, and have just a much easier time gaining weight. And then meanwhile, our bodies have been evolved to be very good at not starving. So think about what happens when you go on a diet to lose weight. And this can be 100 pounds, or it could even be 5 pounds. At a certain point, our body's anti-starvation responses kick in to, again, make us more hungry, think about food more. When we lose weight, our metabolic rate actually slows down significantly. And our bodies basically do everything possible to sabotage our best efforts at weight loss. This is why 80% of people regain lost weight within 5 years of lifestyle interventions for weight loss. So by the time most people present to obesity medicine physicians like me, they've lost and gained weight so many times with greater difficulty each time until no strategy is really working because their bodies are so resistant. So our patients often present to us really blaming themselves, thinking that they have no willpower and have given up hope. So successful weight loss, and really more importantly, weight maintenance, requires more than just, prescribing one medication in isolation, but rather a comprehensive evaluation to identify every factor that's leading to weight gain, every barrier preventing weight loss. Lifestyle interventions are crucial, and these include, optimizing dietary strategy, physical activity, behavioral modifications. But because lifestyle interventions aren't sufficient on their own for most people to lose a clinically significant amount of weight and keep it off, this is where medical treatment comes in, including anti-obesity medications and sometimes procedures and surgeries. And these are really the standard of care. The medical intervention is the standard of care per medical guidelines. The medications that we prescribe work in a variety of different ways to kind of fight these body, anti-starvation responses to enable people to actually lose a significant amount of weight and keep it off. The GLP-1 receptor agonists, which I know we'll talk quite a bit about today, are just one example of the agents in our armamentarium, which all need to be customized for each individual patient and prescribed with a lot of education and support.
So just so it's clear, the GLP-1s, are they the only ones that are available today for obesity, or are there others?
Great question. So the GLP-1s are not the only agents available for obesity. There are about 6 main medications that are FDA approved for weight. And each of these medications are in classes of medications where we can sometimes use another agent in the same class that works the same way, but doesn't have the indication of obesity. And some of the medications are made up of generic components that we can use kind of strategically to help with weight loss as well. So we have a whole range. We have a whole armamentarium of medications, and really the expertise of an obesity medicine provider is to be really, really, really good at figuring out the right medication for the right patient, or honestly, the right combination, because obesity is so refractory that it often takes 2, 3, 4, 5 medications sometimes, and it's all a risk benefit. And then figuring out how to prescribe these in a way to make them extremely safe, tolerable, and then fine-tuned, because things don't, just stay stable forever. Stuff comes up and we need to, really problem solve and figure out why things are changing and adjust medications. And this is a long-term thing.
So based on that, in advance of today's webinar, Christy and I spoke, and the Stop Obesity Alliance has done a lot of work on what optimal care actually looks like. We've read a lot in the news about the drugs, right? And just taking the drugs on its own, as our panelists have already said, is not the magic bullet, right? So we asked Christy to kind of present what an optimal care strategy looks like. So if we can put those slides up, Christy will walk through that.
Thanks, Bunny. So in around 2009 or so, STOP began to look at what coverage looked like for obesity treatments. And of course, this was many years ago, well before we had a lot of the treatments that are available now on the market. But we began to look at coverage mostly at Medicaid and state employee health plans, because those brochures are public. And so what our researchers at the university kept telling us was, this is a very tedious project because there's no standard of coverage. When you're searching for something in your health insurance plan, it could be listed under obesity, diet, weight loss, all kinds of other ways of listing what is available for treatment and coverage. And so that work led us to putting together a comprehensive obesity benefit. Just to clarify, this is evidence-based treatment that through our research, we argue health insurance companies should include in what they offer to their beneficiaries for both obesity prevention as well as screening and treatment. So there are 5 elements. They're listed here: prevention and screening, intensive behavioral therapy, which includes a physical activity component, and nutrition therapy, as well as cognitive behavioral therapy, motivational interviewing, so forth. The third is pharmacotherapy, and then bariatric surgery. And we also included a weight maintenance for our plan. So next slide. So just going further into some details on this, for prevention and screening, we follow the USPSTF guidelines that all adults should be screened annually for obesity. Diagnosis of obesity should be given to adults with a BMI greater than or equal to 30. And then we also include waist circumference here. There's a lot of debate right now about whether how good of a diagnosis tool BMI is. And so we are looking at what else should be included in that definition. And then if someone is diagnosed with obesity, they should be offered and referred to an intensive lifestyle intervention, as well as screened for obesity-related complications. Next slide. So just a little more about what we believe should be included in the intensive behavioral therapy. Again, it should follow the USPSTF guidelines and offer at least 14 or more counseling sessions per year, which is actually less than the USPSTF guidelines, but we feel is sort of a reasonable amount. And then it should have a physical activity and nutritional component that includes a program for low-calorie diet and a plan for at least 150 minutes of physical activity per week, as well as maintenance and follow-up. So some folks, this IBT plan will help them lose the weight, but they should also have maintenance and follow-up with their provider. Next slide. And so pharmacotherapy, as we mentioned already, there have been several medications on the market for a while. Some are very old, like phentermine. Some of the newer ones are Wegovy and Saxenda. And then Contrave and Qsymia are ones that have been on the market now for about 8 years or so. So the other thing that we really push is that there should be weight-centric prescribing. So what this means is if you are prescribed, say, an anti-anxiety medication, and you also have obesity, or you're kind of on the borderline with obesity, or it runs in your family, you should be able to access medications for that other disease, the anxiety, that you should be able to access medications that won't also make you gain weight. So we think that's very important. Next slide. So metabolic surgery has been around for quite a long time. We argue that there should be coverage for the primary bariatric procedures. Right now, laparoscopy, sleeve gastrectomy, and the Roux-en-Y gastric bypass are both the ones that are most common, as well as there should be coverage for a revisional procedure to correct any complications. And next slide. So again, as I mentioned, we do also have a weight maintenance coverage in here. So this is also really important, especially for these new medications where there is quite a significant amount of weight loss that happens in over a couple-year period. And so patients should be able to also have monitoring and prevention, continue to talk to their providers and document sort of their weight status. And if they need sort of reinitiation or sort of intensification of their treatment plan, that should be covered as well. So next slide. So just real quickly, all this is available on our website. We also include a comprehensive obesity care benefit checklist. This can be used by employers, patients, really anybody, providers, anyone who wants to go in and check what they offer, and also what their health plan offers, or if a provider needs help with their patients seeing what's available, this is a great checklist that they can give to their patients. So thank you.
Sorry, I was muted. All right, so this is the ideal. And where have you seen this actually implemented anywhere?
That's a really great question. And we have recently seen this in the guidance that the Office of Personnel Management, so that's the federal government, has provided to the federal employee health plans. So in their carrier letter that went out in January, it included all elements of our comprehensive obesity benefit that they say needs to be covered. Now they do modify it a little bit for the medications. We say all medications should be covered. They modify it. I think it's 2 medications and then at least one of the GLP-1s. So there is a little bit of a difference, but it's actually a really great model that we hope others will follow.
Okay, so we have the ideal model. We know obesity is a chronic disease. And the only thing that's really getting a lot of attention are the new drugs, right? Wegovy and Ozempic. And actually Ozempic is, Mark, I'm sorry, Max, what's the difference between Ozempic and Wegovy?
So when we actually take a deep dive, like, so when you look at Ozempic and Wegovy, the active ingredient is the same, but when you take a deep dive into the dosing and the FDA labeled indication, Wegovy is the only one that's actually FDA label indicated for obesity. Ozempic has an FDA labeled indication for diabetes. It's a very good question. It's very important to delineate here for as far as what we're talking about, as far as the FDA indications, because it's important to have these indications, both for patient safety, for our clinical management, everything like that. And there's a reason why we have these indications and why the dosages are different. Because the way we manage these patients, the way we do everything is really based on a lot of the clinical trials and the studies that are out there for that.
All right, so let's get into the meat of what people want to talk about, which is money and cost. And Max, you're the expert here on some of the cost and utilization trends regarding the prescription drugs. So we're just going to show a couple of slides.
Yeah, so Bunny, I appreciate it. I'll give a tiny bit of background on my organization. So Valued Pharmacy Services, we're the pharmacy branch at NFP. So NFP is a major international insurance brokerage firm. We cover on the pharmacy side nearly 2 million covered lives, either from our coalition business or our consulting business. What makes us unique is our heavy clinical focus. So we have over 15 pharmacists on our team, but also a really deep dive and really heavy focus on analytics and live claims. So with that live claims, we really look at industry trends, and we've really seen large increases early 2022 in different pieces like this, as far as with the GLP-1s. So we're looking at the 6 medications, basically from the right over, looking at Trulicity to the right. Those are all going to be GLP-1s. And we saw really interesting trends, and it's really looking at, I would say, and the number was quite phenomenal. It's actually, when you look at the second half of the first half of 2022 versus the first half of 23, it was a 90% increase in utilization. And so I just wanted to take a second to let that sink in a bit. A 90% increase in utilization. And the reality is a lot of this is being driven by medications that aren't necessarily new to market. So we had to really take a step back and evaluate what's causing this, right? And so we've already kind of talked about, we've mentioned the media blitz, we've mentioned, kind of alluded to celebrities, different things like that. But it's also kind of this underlying, we haven't really had management or oversight of off-label utilization. So a lot of the medications that may be truly indicated for diabetes, we're now seeing a lot of usage for weight loss. And so we're now seeing that evolve kind of in our utilization trends. And then if you go to the next slide, we're also seeing that transcend now into some of the planned spend associated. So if we look at the second half of 22 versus the first half of 23, that's leading to increase in planned spend of over 20%. And then when we annualize that for 2023, that's a year to date, we could potentially see an increase in over 35% for our year over year spend just in GLP-1s. And then this PMPM, which is a per member per month, this is a common metric that we use in the pharmacy benefits space. This is a predictive modeling done by one of our big PBM partners. And this is kind of a predictive modeling that's being done to see what the increase in spend is like, or what we predict over the next few years. And it's just kind of one of these questions where we know from a clinical perspective, having availability to these medications is the right way to treat members. But we also have to have a financial lens and do it in a fiscally responsible way. So being as transparent as possible with our HR teams and letting them know what the costs associated may look like.
Okay, so no doubt this is a great advancement in treating obesity. When you look at these numbers, you think about sustainability. You have articles saying that companies are already turning off coverage. So this is to everyone on the panel, because I'm sure you're dealing with this, question. How do we make this somewhat sustainable? And what are procedures that companies and employers and health plans can do to mitigate some of this risk? Because it's real.
I'm happy
Bunny,
to.
I'll just start with one thing to say, and I think that's a really significant number to say, that there's been this increase of 90% utilization. That's a whopping figure there. But I think it's also important that we not sort of say that means that 90% of people with obesity are getting this treatment. And so what we're really seeing is that utilization is still quite low in people getting the treatment that they need, as well as utilizing these new medications. And so the reason for that is there's several things that are happening, but providers are not always trained in how to treat obesity. Patients with obesity don't feel comfortable asking for help. They often don't go to the doctor at all. And when they do go, they're told that they just need to eat healthier and exercise more. And also when people do start these medications, there are a lot of side effects. They might not work for them right away. So that what we're actually seeing is the trend of how long they're staying on the medications is not more than a couple of months. So those aren't all positive things, but it's just something to point out that we're really seeing a very low utilization rate still of the medications. We're seeing somewhere between 2 and 5%. And really, realistically, we think there will probably be 10% or so over the next 5 to 10 years.
I'm happy to add, I think one of the things that's been happening is this sort of like robo prescribing of GLP-1s. So prescribing GLP-1s off the bat, in and of itself, that's, not a sustainable way of prescribing just because of the price of the GLP-1s right now. But they also need to be done with the appropriate education, support, and the appropriate workup to make sure this is the right medication, that it's, prescribed in a way that mitigates side effects and sets people really up for success. So I think the answer is not just, not having coverage for treatment. The answer is to do this in a way where there are guardrails. So not giving every single patient a GLP-1 and using all the medications that we have available. Also doing a comprehensive evaluation of each patient. Like, this is a whole field of medicine. A typical patient I see has 10, weight related health complications and more that we're diagnosing. And so if I see someone and just give them a medication, nothing else, we're not identifying undiagnosed sleep apnea. We're not identifying, as Christy was talking about, potentially multiple medications that are leading to weight gain. So this really has to be done at a high level to, one, save money, but two, set people up for success and provide enough education and support so that they don't just take the medication, don't do anything else, and then stop after a few months. And then they're in a worse position, literally, than if they had never taken the medication to begin with.
It's really important that employers, we're seeing that in the newspaper articles that are coming out with sort of some employers just saying, no to all these new GLP-1 drugs, which isn't really the solution. At the moment, obesity is costing employers a significant amount of money with all the comorbidities and all the associated diseases and other aggravating factors, which, they've got to take into account. So just not covering AOM, anti-obesity medicines or the new GLP-1s isn't going to solve the problem. We know the problem's been getting gradually worse for the last sort of 30 years plus. So employers need to think differently about how they do this. So there's obviously some cost benefits from there are benefits from putting it in, because you can reduce the costs associated with diabetes, cardiovascular disease, and musculoskeletal problems, and all those sort of things. So there's savings there. But I agree, there does need to be some guardrails in here. Not, as you say, there's many providers out there who are nearly robo-prescribing, because that's a way, it's easy, you don't have to think, you just prescribe and the patient's happy to get what they want, but then 2 months later they give up on the treatment and and they don't lose any weight, or they lose a little bit and they come straight back again. So we do need to make sure that this is, it's designed for the right patient, with the right treatment, with the right support mechanisms and that network around them. And that's what employers, I think, if they start looking at benefit design, need to start thinking about some of those elements and really building those in. So then it's not going to be cheap. There's still, at the end of the day, there's a lot of Americans who living with obesity. There's a lot of people who are overweight who sort of might well progress. So there's a lot to be done, but at least there is some hope. And at the moment, it's sort of behavioral therapy or bariatric surgery, which is a sort of little extremes on both ends. And we know one of them doesn't really work sustainably, all the time. It might work early on, but it doesn't work as the disease progresses. So I do think, we do need to think about these guardrails, how we get these drugs used appropriately so the right patients get them, and both the patients and employers get the most out, get the most out of their healthcare spend.
Yeah, and I will say, we have been recommending for, again, some of the utilization numbers that I presented, they seem phenomenal, right? And we've had some of the PBM partners have come back, and we've looked at some of the, for example, like the off-label utilization. We've looked at some solutions as far as making sure that for the diabetic members that they've used other diabetes medications first, or that, to make sure that they have a diagnosis of diabetes first. So it's kind of more of a logic or a softer edit in place. It's not like a full prior authorization or things like that. And honestly, it's actually led us to, it's almost been a catalyst to have a more educated conversation about opening up anti-obesity drugs. Because when these groups or these companies have so much increased utilization around this space, they start to ask why. Like, why are these now a top drug on my annual review on my list? And we start to explain it's because obesity is becoming such a big hot topic, and clearly your population's using this potentially off-label, and they say, well, what's the solution? How do we do it? And then we can talk about actually opening up obesity as a true, coverage item. And then we can use that, and then we can, go at it with a full-fledged approach of having a wellness program and having a full 360 approach where you're treating it as a disease state versus a cosmetic condition.
I know we have some questions that are coming in on this very topic on the economics of it. One is around, outcomes-based, value-based care or value-based pricing. Have any of you seen that? Are employers trying that? Have any thoughts on that?
So I haven't seen it in this space yet. I know, we've been asking in this marketplace because I think from a clinical perspective, we understand that obesity is the core for so many other disease states, right? We know musculoskeletal health, certain types of cancers, hypertension, like we know treating obesity is the right way to treat patients, but we're still looking for the true direct line data that says, if we open up obesity coverage, you're going to have less hospital admissions. Or if you open up, like we're still waiting for that study in the marketplace. And we don't necessarily have that, data in hand to give people yet.
Right. And actually in the Wall Street Journal article today, that was the complaint, right, among those that decided to stop covering it, is they're not seeing that yet, but it's a very short term. They're looking at it in a pretty short term way. Let's change a little bit to the proliferation of solutions out there that we've seen come on tap over the past few years. Many know that I'm entrenched in the digital health world, and there are a lot of different point solutions, a lot of different companies, and telehealth is one of the companies that have been funded and are looking at treating obesity. It's made life a little more difficult for employers in some ways because there are so many options out there. So I'm just curious, Catherine, we'll start with you since you are an entrepreneur. How do companies navigate all of these solutions? How can they manage?
Yeah, well, I definitely can't comment from the company side as much as, from offering a solution to companies. But what I can say is, we've talked a lot about how treating obesity in a clinically significant way. So helping people really lose a clinically significant amount of weight and then maintaining that weight loss can prevent, improve, or resolve the over 200 related weight-related health complications. So in my opinion, having a point solution that treats obesity is extremely important, and it can sort of reduce, utilization of other point solutions that may be for musculoskeletal or maybe for cardiovascular disease. So absolutely such an important, such an important focus right now, since we finally do have medications and solutions that can make a huge difference. But as we just talked about, it'll take time to get all the data to show, how much of an impact this makes.
Can you just talk a little bit about how your solution differs from, or what's unique about it?
Sure. So yes, we were featured today in the Wall Street Journal. Peter Loftus.
Congratulations. That's huge.
Thank you. So
people still read the Wall Street Journal, I promise.
So he mentioned our program that we're doing with a big state government, their employee population. So this state wanted to start covering anti-obesity medications, but they were terrified about the high costs. And when you read about Texas and other companies, companies and states can literally go bankrupt by saying yes to covering anti-obesity meds. But as we talked about, the answer is just not covering it. It's really covering with guardrails. So we've set up a program with them where we as IntelliHealth, our medical practice, Flight Medical, we are the prescribers of anti-obesity medications for the state employees. So if any state employee wants to start Wegovy or wants to, understand what all of their options are, they come see us. And it's been exciting. It's been about a month, and we've taken over a lot of care that has been happening, suboptimally and just in different ways. For example, people have been coming to us on compounded semaglutide, which is really concerning because it can be very dangerous. We've seen.
So can you explain that? What does that mean, compounded?
Sure. So anytime there's kind of scarcity and a serious need for something that we just don't have enough of, you see other solutions. And some of these compounding pharmacies are actually creating what they're calling semaglutide. If you talk to Novo Nordisk, it is not semaglutide, but they're compounding what they're calling semaglutide. And so you can go to medi spas or go to certain providers who have access to these compounding pharmacies. They often have their patients come in once a week to actually do the injection there instead of doing it at home, which is part of, I guess, the business plan. But the concern is just that we don't know exactly what people are taking. And the FDA has actually come out to say, people should not be using compounded semaglutide. It can be very dangerous. So we've seen a bit of that, and also kind of inappropriate prescribing in other ways. So, what we're able to offer that's different from what's out there is just a very, very, very high level of medical comprehensive care, where we do a full evaluation, we identify all the factors and the barriers that are, related to weight, and we come up with a really, really personalized and comprehensive treatment plan that includes, the right medication for the right patient, prescribed with a ton of education and support. We also use the full range of our armamentarium and not just, robo-prescribing GLP-1s. So that's why this state has come to us to, be the custodians of this. And then we're going to work very closely with them to look at our data and look at claims and be able to put this all together to hopefully tell a very compelling story that could be a model for other state governments, other companies, and the like.
Great. So Mark, what are you're working with employers day in, day out. How are they navigating some of these many solutions? And
I mean, they are incredibly useful, and they can also be incredibly complicated when you've got a workforce that can't navigate the current healthcare system, let alone adding lots of different solutions on top, which solves one problem but doesn't sometimes causes other problems. So it's really a challenge, and often the point solutions, they evolve over time. So you get one in that might be around weight loss, but then they start doing some other things that cover other health conditions, and then you have overlap in benefits, and it gets very complicated. So it's a constantly changing dynamic field. But saying that, most of our major employers, they have a number of point solutions in place for a number of conditions. And it's really a matter of communicating and trying to help people navigate through the company's, generally fairly generous and fairly complicated healthcare benefits, so people understand where to go when they need it. But also, I think one of the things, I think so point solutions is definitely something that employers can do. But I think also employers, because people spend a lot of time at work, have a big opportunity to try and have the right sort of develop that culture of health that really tries to help people do the right thing. So whether that's around building design, so people nudge and walk and do the slightly right things, that healthy nutrition at workplace, but also all the peripheral things that are needed to support somebody who's going through their an obesity journey, to help them on that journey. They can help provide that while they're at work and outside work, and point solutions can be part of that. So I do think employers have that ability to be a little bit downstream or upstream in terms of trying to prevent people from transitioning and moving and tracking those people and building that right culture in place. But also they're often holding that design feature around the benefit design and what they're going to cover and what they're not going to cover. So they do really have a key part to play in this. And I think, there's a lot of the employers are still sort of thinking how we're going to do this. They want to cover, they understand that these new medicines are great. They want to add the right point solutions to try and help people. And over the last few years, we had point solutions in many different areas, which have been incredibly helpful in terms of reducing barriers and getting better access. But one of the other things I think employers have is the opportunities from some of the work we did was obviously there is a diversity and equity issue around obesity as well, in terms of making sure that we look at things through a sort of diversity, sort of equity lens, because often it's people of color, women who are in the less well-paid jobs who really can't afford some of the co-pays and everything else. So it's really about designing benefits that are accessible for all as well, but also that culture in the company where people come forward. Because I think, Catherine, you said that, there's a number of people who don't come forward and don't access treatment because they're embarrassed. They feel it's their fault, they failed, so they don't want to come forward. So employers can help with, reducing stigma and also increasing access, but also doing it across the whole of their workforce, not just for the sort of, for the sort of management and above and, the wealthier employees, but for all.
Max, what do you hear from your employer clients, especially around ROI?
Yeah, I mean, again, I think when I'm talking to them about it, it's still one of those, the general conversation of, from a clinical perspective, we know it's the right way holistically to treat members. Overall, when you look at the general cost of these medications, it's not intended to be like the GLP-1s we're talking about. They're not intended to be like direct to consumer type price products, right? They're between that $900 to $1,400 a month products. So they're not like your Good RX or your Mark Cuban. So like those aren't going to be the solutions there. These are intended to be like your employer covers the product, you get it through your insurance and things like that. So to Dr. Mark's point, there is going to be that like equity gap, but I feel like there's more and more coming out about like the willingness of people to pay X amount, they're willing to pay. And I think that's where we're running into some of the issues with like the compounding pharmacies and different health spas and stuff like that, where we're running into some of those issues. I think the comprehensive design that Christine outlined is huge. Having a full wellness program, like something like that, as robust as that sounds great. But to be honest, it's so new at this point. I've yet to like get like a full feedback to say like, hey, we opened up coverage and this is the feedback I'm getting. Because as I mentioned before, it's always been for so long in my space, something we just skipped over. It was so easy just to say like, don't cover these meds because there haven't been good products in the space before. But the science has advanced so much over the last few years and the attention around it has improved so much, but now you really can't ignore it.
So let's look at the future. It's still new, but we've got new drugs on the horizon, maybe new treatments, maybe new legislation. And we have a question here, which is a great one. In 3 to 5 years, prices will start coming down. And how are we all going to change our outlook then? So feel free to chime in on what we expect to see in the next 3 to 5 years in this market.
I think fundamentally, we would like that to be the concept, right? Fundamentally, we think more products come in and more competition means the price drops. But realistically, with the patents and the laws and different pieces like that in place, it's understandably, I think it's going to take more than 3 to 5 years before we realistically see the price drop in a significant manner before we see that kind of price reprieve. So I think what will be interesting is to see the science behind what kind of weight loss we see with these new products, right? So the clinical trials and what kind of percentages of weight loss we see with these new products to see, are we going to get to the point where a bariatric surgery is no longer even going to be recommended? Are these new products going to get so good that bariatric surgery is not even on the table anymore? And now we have to start evaluating, are these injectable medications going to be that effective and that clinically safe that we have to start doing like these analysis financially to see, how long, can we get them there, and then start looking at wellness programs and pieces of that. That's kind of my thoughts on it.
I'm happy to go over some of the agents that we can expect in the next few years if people are interested in that. The obesity pipeline right now is really mind-blowing. So the next medication that we're expecting is tirzepatide, which right now is FDA approved for diabetes under the brand name Mounjaro. But this will be approved for obesity. We anticipate by the end of the year, I hope, it will be a different brand name for obesity. And actually in data that was released this week, tirzepatide was associated with 26% total body weight loss, which is really incredible. There are also oral versions of semaglutide. So again, semaglutide is Ozempic, Wegovy. Those are injectables. We right now have a low dose oral version called Rybelsus, but a higher dose, 25 to 50, will be approved sometime next year for people who don't want to do the injections. And then the future really is going to be in combination treatment. So the reason why tirzepatide is more effective than semaglutide is that it targets 2 different receptors. And so going forward, we're going to be looking at combinations of 2 receptors. There's a medication that actually targets 3 that's called triple G. So triple G and another agent from Novo Nordisk, triple G is Eli Lilly. Novo Nordisk has CagriSema. Those agents will be or are associated with significantly more weight loss. And then there also are investigations ongoing looking at novel agents where body weight changes in a different way. So as people lose weight, muscle loss is a concern. And so we talk to our patients a lot about doing strength training and everything that we can do to hold on to muscle mass. But some of the newer agents that are under investigation actually help people maintain muscle loss as they're losing weight. So those are just, a couple of a couple of things to look out for in the next couple of years. It's going to be really, really, really exciting.
One of the things I hope that we'll see in the next 3 to 5 years is really some more data on this return on investment that we're talking about. We really need to collect that data and be able to sort of show employers that are paying for these health plans, as well as the federal government, that it needs to invest in covering these medications, both for their own employees as well as Medicare and Medicaid populations, is that they're going to see a change in the cost for other diseases that are related to obesity. So we're hearing from providers that diabetes is going into remission when people lose a significant amount of weight, and other things like their sleep apnea gets better, so they might go off of the mask that they wear. The osteoarthritis gets better, all kinds of other diseases or other things might change. And if we can get that ROI and get it sort of quantified, that is really, I think, going to help us, especially with everything that Catherine just mentioned, everything that's going to be coming onto the market. It's really, I think we're about to explode in this area. But then I just sort of want to take a little bit of a backtrack and also say what I really, really hope over the next 3 to 5 years is that people that are living with this disease really feel more comfortable going to their providers, asking for help, engaging in treatment, because right now there's just so much bias and stigma out there against people with obesity. We still use terms like obese, which just is like, when I hear that word, it just grinds me because it's just such a negative connotation. And people, I think if we were to replace obesity with, like, say that all of these medications and so forth and treatments were available, but it was for a different disease, we might actually be thinking about this differently. Like, what if we were saying that this was, all just for diabetes? We might even be saying, providers and employers might be saying, sure, we'll cover this because it's great and because diabetes is a true disease. I think there's a lot of internal bias where people think that obesity is not a disease. And so they're like, well, I don't really want to pay for this because it's just a lifestyle change. So I think that's sort of the shift that needs to happen.
So in the last did you want to say something, Mark?
No, I think building on that, I do think, this concept of of obesity being a disease, and even society, society and governments treating it as disease isn't really quite there yet, because it's the biggest public health, problem probably in the US and many other countries, but it's still not really being addressed at some of its root causes. So hopefully eventually some of that will change, but that's, probably a complete pie in the sky, no pun there. But it's sort of that sort of hope of that, that we move away from these ultra processed foods, and and this sort of ability to sort of pack as many calories in and sort of not to satiate people, and so they just keep gaining weight. And unfortunately, that just seems to be getting worse. I know there has been some trends in the food industry to try and address that, but overall we still consume, far more. I think it's up to about, I think the last century has gone about 60% of our diet now is ultra high processed food. So it's until we start addressing some of those issues, these medicines and everything else are going to be fantastic at trying to help a number of people. But if we just keep getting the supply chain is completely filling up, every day we sort of get somebody off, we've got another 10 people coming in. That's where the challenge is on a big public health scale, especially just getting younger.
I was going to actually ask for, what do you want people to remember from today? And Christy and Dr. Cunningham Hill, you both said it. Catherine and Max, I'd like each of you to kind of reflect. What would you like folks to take away from today?
I think for me, ultimate take-home message is just if you're in HR, if you're doing benefits design, is just go back and ask questions, right? You may not know if you're covering obesity today, and that's okay. Talk to your broker, talk to your consultant. If you have a direct relationship with your PBM, just poke the bear, like figure out like what's available to you in your current setup, whether you're carved in, carved out. Just ask questions. Dr. Saunders really outlined like the pipeline for this is robust. These conversations are not going away. Members are expecting it. Like this is not going away by any means. So please ask questions, get educated on it, because it's important, and the conversations are happening.
Yep, totally agree. I think the answer, again, as I said before, is not saying no to anti-obesity medication coverage, but doing it appropriately, and having the right guardrails in place. So, who's prescribing the medications? Do you even know? Are you, paying attention to, where these medications are coming from? Are they real medications? Are they compounded? Understanding, what kind of care is being delivered? Is it comprehensive care at a very high level, or is it just, prescribing medication with nothing else? So really kind of figuring out status quo, and then figuring out how to approve the medications, but in a way that's very responsible, so that we can achieve, effective obesity treatment that's also cost effective.
Okay, well, with that, we've covered a lot of ground in an hour. Thank you all so much. Thank you, Dr. Cunningham Hill. Thank you, Christy Gallagher. Thank you, Dr. Saunders. Thank you, Max Cartman. Thanks to everyone who tuned in. I hope that you got as much out of it as I did.